right, so we're going to go ahead and get started. I hope that everyone can hear me, and I hope that you can see my slides. So if you can just put in the chat if you are able to see my slides, my video, and hear me. All is well. Okay, perfect. Thanks, Jessica. There seems to be some difficulties. I'm getting a lot of texts from folks that they're unable to get into this session. I'm not sure what that's about, but we're going to go ahead and go forth with the session as is. I have heard that there's some IT and technical difficulties during NCPHA's fall conference this year, but we all kind of need to just take one step back and realize that we're in a very interesting time, and utilizing technology sometimes does not work the way that we would hope that it would. But we're going to try our best, and so I'd love to keep presentations interactive, and so I'm not going to be able to see the chat while I'm actually presenting, but I am going to toggle back and forth every so often just to see if there are any questions that come in the chat that I can answer. I'm unable to share my PowerPoint from PowerPoint directly, so the only way I was able to share my slides with you all is actually through the browser. So if you can see them, then we're good, but you're not going to see the quick flip of the slide like you normally would with a PowerPoint. You'll see me scrolling through because this is off of Google Drive. So I'm going to go ahead and get started unless there are any questions. All right, perfect. Jessica, if I continue to get questions from folks, I will make sure to send your number to them. But I was getting them kind of around 1:40 or so that people could not get in. I'm not sure what that was about. And hi, Robin. It's good to see at least your name on the chat box. So I hope you're doing well as everyone else in the session. All right, so what we're going to be talking about today is teledentistry. And so this may not be a new concept to the folks that are in the session currently, or maybe it is new to you, but I'm going to go ahead and give you a really in-depth overview of teledentistry, particularly how it helps bridge the rural-urban divide in terms of access to care. So I want to start with just disclosures and let you know that I represent the North Carolina Oral Health Collaborative, which is a program of the Foundation for Health Leadership and Innovation. But I do not have any relevant financial relationships to disclose as it pertains to this presentation. You also will see the oral health section, continuing education program disclosure at the bottom. So I'll give a second for folks to read that. I'm sure that you've seen that in other slides in other sessions as well. All right, so I really like to kind of make presentations interactive, as I had mentioned. So I'd love to hear from folks that are in the room. Specifically, what is your position or your role within the field of public health? Are you all dental folks, or do we have any non-dental folks in the room? So feel free to put in the chat. Perfect. So I see all dental so far. Anybody else? All right, so all dental so far. So this may be a repeat for some of you, but I do hope that you ask the specific questions about teledentistry that you may have. And I'll be talking about my background and my history with teledentistry and how I've used that personally in clinical practice as well as from the policy perspective. So a little bit about me. I think at least the folks I've seen in the chat, you all know who I am, but just as a repeat, I am directing the Oral Health Collaborative, which is a multidisciplinary coalition. We are focused mostly on state oral health public policy and payment reform, but we also do some direct technical assistance for safety net facilities across the state of North Carolina, including FQHCs primarily. Prior to coming to North Carolina, I'm not a native North Carolinian. I'm actually from Kentucky, and I was in private practice in Kentucky for a while, and then made my way to the Upper Peninsula of Michigan, where I directed several Indian Health Service sites with the Sioux Tribe of Chippewa Indians. And then from there, I worked in partnership with Yale University in Connecticut, where I directed a federally qualified health center that they had a partnership agreement with. I got my dental degree from the University of Louisville, and then I went on to get my Master's of Health Administration from Central Michigan University. So a little bit about the North Carolina Oral Health Collaborative. I think at least several of the folks on this session are familiar with our work, but we promote innovative oral health programs. We provide a lot of technical assistance, as I had mentioned, and really at the heart of it is we're trying to create systems level changes that increase access and equity to optimal oral health services across the state. So I'll take a second, let's see. No questions so far. All right. So I'd be remiss if I did not talk about the oral health status in North Carolina as it pertains to what we're going to dive into a little bit later, how teledentistry may service those access gaps. So I think it's not going to come to no surprise to any of you all that access to oral health services is definitely not commonplace in North Carolina, nor do we feel at the collaborative, at least, that it's equitable. So this actually was just released from HRSA. The dental health professional shortage areas were just redesignated. And so prior to 2020, we had 74 out of 100 counties in North Carolina that were deemed a dental health provider professional shortage area. And now, as of 2020, at least in August of 2020, there are 98 now out of 100. So a couple things to note, when we say 98 out of 100 counties are deemed DHIPSAs, that could be all of the county, it could be partial pieces of the county. And I'll give you one example. Mecklenburg, Charlotte is deemed a DHIPSA, but not the whole county as a whole. So you can go to the HRSA website. This screenshot that you see is directly from HRSA, and it will show you what the DHIPSA score is. As we know, the higher the number, the more significant the need is in terms of access to those oral health providers. And 98, again, out of 100 counties are deemed DHIPSAs. The larger issue, I think, is not just, it's not as simple as saying we don't have enough dentists in the state. I think one of our largest issues in the state of North Carolina is not the number, but it's the maldistribution. So when we look across the state, this is from the North Carolina Department of Health and Human Services and the Shep Center for Health Services Research at UNC. It is deemed, this is in 2017, that dentists, the majority of dentists are concentrated in 1/5 of all North Carolina counties. So when you look at this map, the darker the green, meaning more providers per population. And that's significant. When you think about there are 100 counties in the state and 1/5 of those hold the most practicing dentists, what about the other pieces? So it's not a great statistic for us to have, but that's why I say I think a lot of it's to do with the maldistribution, not necessarily the number. So I wanted just to hear from you, how do disparities in oral health impact your work in public health? It's probably going to be an easy answer for a lot of you because you are in the dental space. But how do disparities in oral health impact your work in public health? So go ahead and just put in the chat there. Don't be shy. Exactly, Robin. So you're saying linking people to care, especially for the IDD population. Absolutely. When we think about public health, we think about population health. And that's really what we're trying to achieve here is a health of a whole population and not at the individual level. If folks in particular areas, for example, geographically have barriers to access to oral health care, that's not going to bode well for the oral health of those residents in that county, for example. All right, so how does that relate to rural oral health? Rural areas tend to have fewer dentists per capita, so that's what this map is showing you. And the source is the same, Sheps and DHHS. So the darker the green, that is where there are more dentists per the population. So when you look at rural areas, and there's a little kind of reference point here in terms of the highways, you'll see that the further away you get from the highways, the more rural it becomes, and the less dentists are in those areas, in those rural areas. The dental workforce in the state of North Carolina, there are 5,388 dentists and 6,363 dental hygienists that are licensed and actively practicing in North Carolina. And this is a statistic that was taken from the North Carolina State Board of Dental Examiners from their summer 2019 newsletter. When we think about the number of dentists that are licensed in North Carolina and the number of hygienists that are licensed in the state of North Carolina, we need to really think about, are they actively practicing? So that number of 5,388 is much lower than the total number of dentists licensed in the state, but the 5,388 are those that are actively practicing, and there's an algorithm that the board uses to determine who is actively practicing. So that leaves us to about 49 dentists per 100,000 people in the state of North Carolina. Myself included, and many others that really love North Carolina. It's a beautiful place to live, and so we're all moving to North Carolina. And so the population is drastically and exponentially increasing, but the number of dentists to meet that demand is not keeping up. And again, I'll reiterate, it's also an issue of where those dentists decide to practice. That ranks us 37th dentist per capita in the United States. Which is really not where we want to be, right? We want to make sure that we have enough dentists to meet the market demand. A couple statistics I find very particularly concerning. In North Carolina, when you look across kindergarten-aged children, absenteeism is approximately 3 times higher among children with untreated tooth decay, and we have a decent amount or percentage of North Carolinian kindergarten children entering kindergarten with decay. So this really impedes their ability to learn. It really sets the stage, for their brain development and success later in life. Also important to note that emergency department visits for non-traumatic oral-related presentation per 10,000 population is significantly increasing in North Carolina. So this graph shows up to 2013. The Oral Health Collaborative has begun to collect data on ED visits for a study that we do plan to publish. And what we're seeing is that that trend is continuing, and that's very alarming. So when we think about access to care, if there is not a dentist that maybe accepts your particular insurance, or maybe you don't have insurance, maybe you are self-pay with very limited discretionary funds that you can use for oral health care. They seek services at some location when needed, and that location often is the emergency department, which is obviously, as oral health professionals, we know that's not really the place they need to be, because the source of that problem is not going to be addressed in an ED. And what is really significant to pay attention to is that North Carolina is exponentially increasing at a much higher rate in terms of incidence of ED visits compared to that of our counterpart southeastern states. So if you look at Tennessee, Kentucky, South Carolina, we're trending upwards where they're trending downwards. The green line represents the US as a whole, which is also trending down. And that data, I'm not sure where the US stands as a whole past 2013, but I can tell you at least where North Carolina is. Any questions about those slides that we've gone over so far? Why do you think we were trending upward? Jessica, it's a really good question. I think it's very complex. I definitely think it is an array of different issues. I think maldistribution of oral health providers, I think number of providers that are participating in public insurance options such as Medicaid, and where those dentists are choosing to practice, I think all play a role. So for example, if you're in a very remote or rural county in the state, and there's one dentist within 45 minutes that accepts Medicaid, for example, but that dentist no longer is seeing new Medicaid patients, that does not equate access. So there are stories that we hear directly from the ground of folks in this state that have to travel sometimes upwards of an hour and a half one way to be able to seek oral health services, which, as you can imagine, the social context of that is that some of these folks may not have reliable transportation. They may not have an option to get to the dental office. The other issue, Jessica, I think, is the hours of operation. So if a dental office closes at 5 p.m., but you are a frontline worker and you do not have paid time off, and you end your day at 6:30 or 7 p.m., but there are no dental offices open at that time for you to seek services, and you have an urgent need, you will end up in the emergency department. So I think it's very complicated. I think it's complex. I'd be happy to kind of chat after, to really dive into that a little bit further. But those are some of the reasons, at least we anticipate there being barriers that create the incidence increasing in emergency department visits. So this just shows the ED visits per dental condition in North Carolina across the state. So the darker the color, the more incidence of those ED visits. All right, so when we think about racial disparities as well, that translates directly into rural communities also. So this data comes from DHHS, I believe the oral health section. And so this shows racial disparities in oral health in North Carolina. The red bar blocks that you see, that is when the oral health outcome or whatever the measure is worse than the control group. In this instance, we would use the control of white or Caucasians. So this asked in 2016, adults who have not visited a dentist or dental clinic within the last year, 32% of white folks had responded that they had not visited a dentist or dental clinic in the last year, compared to 44.5% of African Americans and 51.2% of Hispanic or Latinx. So the racial disparities that we see are directly correlated to many of the other social determinants of health that we have been able to track across North Carolina. And I know that NCPHA is also engaged in that work. So definitely, if you all want to talk offline about what we're tracking in terms of SDOH, I want to make sure that there's an opportunity for us to discuss that. All right, so the urban-rural divide. So we've talked a lot about, rural communities may have larger barriers to access to oral health services. When we look across the state of North Carolina, according to the North Carolina Department of Commerce, the green areas in our state that are dark green, they designate as rural. So that leaves us to about 40% of North Carolinians live in what North Carolina Department of Commerce would designate as a rural area, which is over 4 million people. What's interesting is if you take the maps that we've seen so far and overlay them together, you'll see the connection. All right, this is also important. We've talked about the distribution issue, but from 2013 to 2017, the change in dentists per 10,000 population has not been uniform. So 72% of North Carolina's dentist workforce growth occurred in 5 counties: Buncombe, Mecklenburg, Orange, Pitt, and Wake. So when you look across the state, we're not trending in the right direction. So we're not seeing more providers, at least on the data that we have currently available, that are going to rural communities to practice. We're actually seeing that the most growth in terms of dentists is happening in 5 counties. And that was over a span of 4 years. All right. Why is that significant? We know from our work that oral health in rural North Carolina and health in general, in terms of overall systemic health and well-being, folks in rural areas in North Carolina have higher rates of chronic disease, a higher percentage of an older adult population, which, as we know, Medicare does not have a dental benefit. We'll throw that out there. And also, there's limited availability of oral health workforce. So we saw that from the maps that I just showed you. Higher rates of unemployment, underemployment, and poverty, lower rates of dental insurance, whether that's public or commercial, greater dependence on public insurance coverage, such as Medicaid, and lack of public transportation or reliable private transportation. I think that's one in particular that people often forget about, that, maybe 15 minutes to us doesn't sound that difficult to drive to a dentist for an oral health appointment. But for a lot of folks that without reliable transportation, that 15 minutes is a barrier. So this kind of speaks to the larger issue that I was talking about earlier is what are the non-medical drivers of health? So we think about social determinants of health, non-medical drivers of health. They have different meanings depending on the context, but I'm going to loop them together for the purposes of this presentation. And we know from studies that the health outcome, including your oral health outcome, really is largely dependent not on just seeing a dentist or genetics. It's actually dependent on many different things, such as income level, if you have housing insecurity or food insecurity, your education level, your income, your gender, and some of the cultural context as well. All right, so all of that to say really is just kind of setting the stage of why this is important. So why do we want to look at teledentistry and other telecommunications innovations to help bridge the gap between someone that is in a rural community, for example, that can access a dentist, that's in an urban area that can access a dentist versus a rural community that maybe access is a little bit more difficult, and how does teledentistry play a role? So just kind of setting the stage, I think, like I said, a lot of you probably know what teledentistry is, but I didn't know exactly who the audience of this presentation would be. But the history of teledentistry really began in 1994, and it was called the Total Dental Access Program, and it was a military project. And so the Army actually had engaged in the Total Dental Access Program as a way to be able to connect those that were out in the field with the oral health care services or consultation that was needed back at base. And so that was a very successful program. And that's really where kind of the history, at least in this country, where teledentistry started. The American Dental Association then issued its first policy statement, so its first formal policy on teledentistry in 2015. And then a few years later, they actually came up with CDT codes for teledentistry and made those effective January 1st of 2018. So in terms of where states are with teledentistry, although it really began in 1994, there hasn't been a lot of time really that it's been formalized in terms of the association setting, such as the ADA. So that really was 5 years ago at this point. So how does the ADA define teledentistry? They refer to it as a broad variety of technology and tactics to deliver medical, health, and education services. There's something I really want people to understand is that telehealth is not a specific service. It's not really a thing, but it's a modality. It's a collection of means to enhance care and education delivery. So it's not changing what we do for patients, it's changing how that's delivered. So I think a lot of times there's a confusion that teledentistry, for example, is a whole new concept, and it requires significant training, such as you would receive in dental school. It's a new thing, and it's really not. So generally, when I give a presentation similar to this in a room full of dentists, I ask folks, raise your hand if you've ever sent a radiograph of your patient to a friend that's a specialist and ask them to provide some consultation or provide you maybe some review for a differential diagnosis. By and large, the majority of all dentists' hands in that setting would raise. And that, by definition, is practicing teledentistry. So a lot of people think teledentistry is this really complex system and it's very complicated. It's actually very simple. You can make it as complicated as you want it to be, but at the very essence of what teledentistry is, it does not need to be complicated. It's much different than, say, telepsychiatry, teleneurology or telecardiology. So I had mentioned previously when I was with Indian Health Service, this was 9 or 10 years ago at this point, we actually were engaging with cardiologists for our tribal members. And so they had a remote EKG, and they could actually perform consultations remotely through this very large machine that they would wheel into the room with the patient to transmit that data. In teledentistry, the barriers to entry in terms of what we need, the armamentarium, for example, is very light. An intraoral camera, perhaps a teledental HIPAA-compliant software system, and that's really it, and an electronic health record. So it's much more it's engaged with much more easily in terms of teledentistry versus other parts of telehealth. So just keep that in mind. So image quality is something that I often get asked about. So some of these images are images I've taken, some are not, but you'll see that the image quality actually is quite good. The intraoral cameras that we have now are relatively inexpensive, and they provide a very high quality image. So this would be asynchronous teledentistry, for example, where we're not doing it in live or real time. So there are two types. I had mentioned the CDT codes earlier. There's synchronous teledentistry that has a CDT code and asynchronous teledentistry that has a CDT code. This would be an example of both, really. So on the upper left, you see the monitor. This was actually a live consultation. So this was transmitted live. So this was a hygienist that was actually live streaming a video to a remote provider to assess what they're looking at. So as you can see, you can really tell clinically what's happening with that tooth. Then you'll see there are images on the right side of the screen, so labeled A and B. Those are intraoral images that were taken as still images and then uploaded to the electronic health record for the dentist to review at a later date and time. The other piece that where I think most folks dip their toe in the water, so to speak, of engaging in teledentistry early on is using intraoral cameras for patient education. So you can see where there is a red oval and it says number 30 fracture. I don't know how many times, and the folks on this session can probably also attest to this, how many times that you tell a patient, you have a fracture, we really need to remove the existing amalgam in this case, for example, and extend that prep to take care of the fracture and trace it really to make sure that it's not extending further than what it appears to be on the surface. And they really just don't understand because it doesn't hurt, they can't feel it, it doesn't show up on an x-ray. And so snapping an intraoral photo, for example, really helps with patient education and helps with treatment plan acceptance. And so a lot of providers in this state that we have spoken to, they use intraoral imaging all the time for patient education. So I'm going to stop there and ask if there are any questions before I move on. Is all of this making sense to folks? Or are they kind of like, what in the world are you talking about? Are we good? Yes. Okay, perfect. So on the screen, you'll see 4 types of teledentistry, and these are just the market definitions. And so again, teledentistry is telecommunications to provide the services we've always been providing that may not be in person or in chair or in office. They're done remotely. So we already talked about synchronous, so that's a live two-way interaction. That could be between 2 providers. Say, for example, I'm a general dentist and I'm going to refer my patient to an oral surgeon. And often times that patient will go to the oral surgeon for a consultation first and then be reappointed for the surgery. So I have done this in my clinical practice many times. I will actually engage that oral surgeon live while the patient's sitting in my chair, walk through, allow the patient to be introduced to the oral surgeon, walk through what we're seeing clinically and what the treatment plan is. And that is essentially the consultation. So when the patient goes to the oral surgeon, they skip 1 appointment. So the consultation's already done. So they go to the appointment, actually have the surgery. So it really creates this opportunity of efficiency. And then asynchronous, we've talked about really that clinical information is recorded, and that could be really anything. So for example, radiographs, hard and soft tissue charting, etc. That information is uploaded into the electronic health record or into the teledental software platform, and then it is forwarded over. So say that there is a hygienist at a community-based site, such as a school, and he or she is going to collect diagnostic information. And then that information is then uploaded to the EHR and transferred or transmitted And then a dentist at the brick and mortar site is going to log in and actually review that information to do a patient exam, for example. When I was in Connecticut, we used asynchronous teledentistry almost extensively for school-based programs. So we had 2 brick and mortar sites and we had 9 school-based sites across the state of Connecticut. And so by and large, there were opportunities, and sometimes we would engage in synchronous live two-way interaction, but by and large, that was done asynchronously, and I can tell you it was extremely efficient. The patient satisfaction was very high for this type of this type of practice, and the clinical outcomes were actually great. So we were able to build a practice in a school and then use care coordination. And I don't want to get into all the details. I think there was a session on that previously, but we would use dental navigators or care coordination to then connect the folks that once the dentist did the exam based on the information submitted or stored and forwarded over, if they needed restorative needs or they had additional needs that they needed to see a dentist in the office, the care coordinator would route that patient in. And then there are 2 kind of arbitrary terms, and they're used often incorrectly, but I just want to make sure that folks are aware of the terminology. So one is remote patient monitoring, and that is basically any technology that enables someone to monitor their patient's health outside of a conventional dental clinic setting. Now, someone asked me in a previous presentation, can I give an example of that? And the example I would give is there are some practices that I have heard of that are using Oral-B that will record pressure points. If the patient is brushing too hard in certain areas, that's actually recorded via Bluetooth. And then that information is actually sent to their dentist. So when the person comes into the office, they can review a month's worth of oral hygiene. You're pressing too hard on the upper right. You're stripping the gingiva, for example, or you're not brushing for 2 minutes. So it tracks all of that information, and that would be an example of remote patient monitoring. And then there is a very broad term called mobile health, and essentially that's just the delivery of oral health care information through technology. So through a smartphone, a tablet, laptop. That one really, to me, is just teledentistry. But the ADA and others have created these 4 definitions. So the 4 types of teledentistry: synchronous, asynchronous, remote patient monitoring, and then mobile health. So I already talked a little bit about this, but what's needed to implement teledentistry in your practice? Very light in terms of armamentarium. So an EHR, intraoral cameras, perhaps if you're out in a school or community-based setting, you'll have a Nomad or a portable X-ray device, and then a teledentistry software platform that's HIPAA compliant. So COVID has really accelerated teledentistry very significantly. And so we have seen several software platforms actually pop up as opportunities. I can tell you, I have personally used Teledent, I've used Doxy.me, and I've had several reviews with the founders of Teledentics so they could kind of walk me through how their platform works. They all are very similar and all offer, by and large, the same functionality. Zoom Health is exactly what it sounds like. It's literally Zoom, but it's a health version that is encrypted, and so that would be HIPAA compliant. It's very important also for people to understand, and I think people have often missed the mark perhaps during COVID. There were some laxed HIPAA requirements during the COVID crisis to really make sure there were not undue burdens placed on the consumer to be able to engage in telehealth, teledentistry, telemental health, etc. But folks should never really be engaging, in my opinion, with a patient that on any platform that's not HIPAA compliant. So for example, I wouldn't pick up my iPhone, and FaceTime with the patient and discuss PHI. I would not do that. And I would not recommend that anyone else do that either. I also would not, use Google Chat or Google Hangouts and things like that. Those are not HIPAA compliant. So that's why these software platforms exist. They offer an opportunity to have a platform to engage with the patient both through synchronous and asynchronously, that is HIPAA compliant. My disclosure, I do have to say we do not endorse any specific product or services, and we have no financial affiliation with any teledental software platform. Okay, so an interesting survey that was done by the American Teledentistry Association, where they were asking a very large sampling of consumers or potential patients how they would prioritize teledentistry. And what the survey responses showed is that 70% of patients are comfortable communicating with their provider via text, email, or video in lieu of an in-person visit. And what's really shocking to me, and I think helps support the idea of moving forward with teledentistry as a codified modality in the state of North Carolina, is that 76% would prioritize access to care over face-to-face interactions. So really, we're all kind of entering in this era, and I think COVID has really accelerated that, where folks are getting very comfortable with communicating via Hopin or Zoom or whatever the platform, or WebEx or whatever it may be, and sharing photos as well. So I think that bodes well, at least what we're seeing in this survey, for us to move forward with teledentistry. Any questions so far about stuff that we've covered in the last several slides? All right. So what do we really hope to achieve in teledentistry? And I call this the triple aim. I'm sure you've heard of this phrase, but I think teledentistry really does have the opportunity to reduce cost, improve health outcomes, and improve the patient experience. I think all three of those have been really, evidence would suggest, studies would suggest, there's a lot of studies going on around teledentistry, particularly out west in California and other states, to make sure that really what we're achieving through teledentistry is increased efficiency, lowering of cost, increasing health outcomes, improving patient experience. And then there's one that often is not discussed, and it's actually not even on my slide, but shame on me, but I like to call it the quadruple aim. And that's really the provider is often missing from this equation. So we say the triple aim is about the patient, reducing cost to the system, and improving the patient experience. But what about the provider experience? So we want to make sure that providers also are feeling really good about using teledentistry and what it can do for their practice. And I will get to this slide a little bit later on, but the Oral Health Collaborative, in response to COVID, awarded $60,000 across the state of North Carolina to safety net sites, which included local health departments, free and charitable clinics, and FQHCs, or federally qualified health centers, to purchase a teledental HIPAA compliant software for an annual subscription to help them better communicate and connect with their patients during this pandemic. And we're collecting quantitative and qualitative survey data from all 19 grantees that we have across the state, and you'll see where they're scattered all across the state, east to west. And what we're finding is that both the provider and the patient experience has been phenomenal. They really, really enjoy this. The providers are letting us know, I feel very comfortable that the oral health outcomes for my patients are as good or better than what we had when we were in person. I often like to say, and I don't usually put folks on the spot in terms of providers, but think about teledentistry for just a moment. If you were able to pause and rewind, for example, as many times as you wanted, how much do you think providers may actually catch in terms of embedding that into their treatment plan? So when you go to the dentist, the oral health provider, I think we all do a great job, but sometimes time is crunched. And so, I think that hygienists, at least on this session, can attest to the dentists they particularly worked with. The exam is quick, right? So the dentist is in and out. But what if that dentist could actually sit and spend 15, 20 minutes, 25 minutes on an exam, and pause and rewind the video and look in detail and magnify the photos and look at the radiographs, and really take their time in designing that treatment plan. There are studies actually showing right now that you can not only diagnose as well during teledentistry, but actually they're showing that you diagnose more effectively. They are actually not missing as many areas when you do that through teledentistry, do the exam through teledentistry. So that's really encouraging as well. And it makes sense logistically. You know, if there are dentists on the session, I'd love to hear from you, but it would be great to be able to pause and rewind. And I used to love doing that whenever I was using teledentistry in Connecticut. All right, so benefits of teledentistry. This is where sometimes people get a little glassy-eyed because they try to understand, how does this fit into my clinical practice? How can I use it? Is it really for me and my workflows? And again, I just want to reiterate, teledentistry is not a one-size-fits-all approach. It can really be designed and utilized in whatever fashion that best meets the needs of your particular practice type. But overall, we can assess that benefits of teledentistry include increasing chair time. So a good example that one of our providers in our FQHCs just told us, and I can definitely relate to them. There are a lot of, say, pediatric emergencies, right? So mom or dad calls and, Johnny is, he has this tooth and it's dangling and it's bleeding and I need to bring him in for a dental emergency. When you connect and actually view in live video stream of what's going on, you realize that that's just a retained deciduous tooth that's attached just merely to the gingiva. So instead of that patient coming in for a dental emergency that really isn't actually a dental emergency, you can free up the chair time and actually have that consultation, save the parent a trip in, free up the chair for another patient for you to see, and it's just much more efficient. So it definitely helps to increase chair time, decrease patient in-office visits when they're not needed, definitely helps increase clinical reach. So as we had talked about before, it really is like an extension and arms for the dental practice to be able to go out into community where we know there is so much need across the state of North Carolina to really make sure that patient is connected to the dentist. They're connected to that dental practice, that brick and mortar site. Helps increase efficiency, potential cost savings as well. All right, so do you think offering teledentistry services could benefit your practice? And I definitely understand that many of you are in administrative roles, but even think back to when you were in purely clinical roles. Do you think that teledentistry has an opportunity to benefit the practice types that you've been in? So I'd love to hear from folks. So go ahead and put in the chat. And there's no wrong answer. If you feel that, based on your experience, teledentistry really wouldn't be applicable or really be useful, then say that, as well. Or if you feel that it definitely would be useful, I'd love to hear that as well. And Rachel, I do see your question, and let's definitely connect, after, and we can discuss. Are people still with me, or are you asleep? It is 2:30, and so cortisol typically is increasing in the body around 2 to 3 p.m. That's why you get a little bit tired. So I hope people are not asleep. All right, well, I don't see anything coming in the chat at this point, so we're going to move on. So we've already talked about a lot of these, but really, I mean, when we dive a little bit deeper into the benefits of teledentistry, particularly for rural communities, ability to reach underserved populations to help reduce their oral health disparities in terms of access, remove socioeconomic disparities. So we already talked about cost savings, the ability for someone to connect with an oral health provider, potentially after hours, and actually see what's going on to be able to accurately triage or diagnose. Improve specialty care and make that more efficient for folks, maybe by saving that one appointment for consultation. The example I gave you about oral surgery, decrease costs, reducing travel time. And the other one that I think that people often don't talk about is just integration. So this is a perfect platform, in my opinion, for us to continue to bridge the medical dental divide, to make sure that we can integrate oral health care into whole person health, into primary care, for example, in pursuit of overall wellness and health. So it does provide an opportunity, and there's some really innovative pilots that are going on across the country. A lot are coming out of DentaQuest. And I can send links to anyone that's interested in kind of reading more about that, but how they're using teledentistry to improve the oral systemic connection, by integrating oral health care more effectively into primary health. Great. So I do see a couple things in the chat. So Jessica, thanks. It says, I think with most of us in public health, teledentistry would help tremendously. I completely agree. We have another response. We are using teledentistry here at UNC Dental School. Great experience so far. Yeah, so we when we were engaging our teledentistry work at the collaborative, we relied heavily on some experts such as Dr. Sean Matthews, that sadly and unfortunately is no longer at UNC, but as well as other folks like Jane Weintraub and folks that were part of the oral healthcare triage line. The dental access resource map that we created really helped kind of route folks that would call into that line. So glad to hear that it's still moving on at UNC. And then Robin says, yes, teledentistry is a benefit. Linking people to care is so important. Absolutely. That's why we're all in public health, right? I mean, we're all in public health, again, in pursuit of improving population health. We think a little bit more broadly. We don't think at the individual level. In teledentistry, I am very confident both in how I've seen it used already in this state and how I have personally used it in clinical practice. I do know that it does help move the needle in pursuit of overall health for a population and wellness. These are just a few applications of impact. This is definitely not an extensive or exhaustive list, but we already talked about school-based programming. I think asynchronous teledentistry, for example, is very vital to effective school-based programs. But also you can use teledentistry in long-term care nursing facilities. I think, we focus a lot on kids, and I think that's great. But there's a large population of older adults in this state for various reasons. Maybe they're dependent adults or IDD, as Robin had mentioned earlier, that have no access to oral health services in long-term care and nursing facilities, and it's very, very sad. Emergency departments, which we've talked about before, and then just obviously, live consultation and review. We talked a little bit about integration with primary care. If anyone's interested in learning a little bit more about what the collaborative is doing around an integration project with primary care, I'd love to talk to you about that and see if you want to be engaged and involved. But we will be going through an IRB process relatively soon on an initiative that we hope we will publish, that will kind of provide a roadmap for other states. So what's the policy environment look like for teledentistry? This is a map from DentaQuest, and so the methodology you can read, for yourself here on the right-hand side of how they come up with the scoring. But sadly, you'll see North Carolina is ranked the lowest. So the dark blue is ranked at a 5, meaning it's the policy environment in that state is most supportive of teledentistry. And then ours being a 1 is least supportive. Now, that map was designed before COVID. And I can tell you, and I'm very, very proud of the work that our North Carolina State Board of Dental Examiners has done. I'm very proud of what the North Carolina Dental Society has done, and I'm very proud of what our Medicaid agency has done in this state. I think we're all trying to move forward with teledentistry as an innovation that will really impact access to care gaps. And we're going to be talking about that a little bit at the end of the presentation. But I put this in just to kind of give you a little bit of overview of where other states were. Many have not advanced beyond that, but I can tell you, I personally think North Carolina um, using COVID-19 as an accelerant is no longer gray. So I hope that DentaQuest redoes this map, which I'm sure they will, because we all know that there have been so many changes to telehealth in general, including teledentistry, both in payment and in public policy as a result of COVID-19. Again, this was reimbursement or allowed reimbursement based on synchronous and asynchronous teledentistry. And this was prior to COVID-19 as well. And I'm going to explain what the differences are at the current time. A couple things to note. The Dental Practice Act and the Dental Hygiene Act is silent on the use of telecommunications, so it's just not in there. So essentially, that's how practices right now and for many years, prior have been using teledentistry. I've talked to dentists in the state that have used teledentistry for years in North Carolina. It just never was reimbursed. And so there was not really an incentive to use it, but they used it because they saw the benefit for their patients. They didn't care if they were reimbursed for it. Again, they're still doing the same services. They're still doing the exam. It's just how they're doing it may look a little differently. So the current statute is silent. It's been going on for years in North Carolina and will continue. But what has changed is that both our public insurance programs and Medicaid in particular, and our private payers and our commercial payers have started reimbursing for teledentistry. So our Medicaid office in particular I cannot say enough good things about Dr. Mark Casey and his leadership and other folks there that really pushed the needle forward and said, we need to make sure that we're reimbursing our providers that participate in Medicaid for the modality of teledentistry during this COVID crisis. It's still left to be seen exactly where they will land in terms of dial-backs, if they'll continue the same reimbursement scheme post-COVID. But in conversations, they're maintaining at least reimbursement. Some of the nuances and restrictions may look different post-COVID, but I feel very confident that our Medicaid office post-COVID will reimburse for both synchronous and asynchronous teledentistry, which is phenomenal. They understand, they've seen firsthand during this crisis the impact it's made for their beneficiaries, and so they want to continue that reimbursement. All right, so opportunities for teledentistry implementation. So how do we get to where we need to go? So I had mentioned earlier that the statute's currently silent, but that doesn't mean that other stakeholders, should not work collectively to codify. So I used the word codify earlier, you probably heard that, and essentially what I mean is, I think North Carolina needs to define teledentistry through legislative action. And I'm not the only person that feels that way. So the Oral Health Collaborative has teamed up again with the North Carolina Dental Society and other stakeholders. There were about 40 stakeholders altogether through a very iterative and rigorous process where we actually designed legislation that we are hoping to collectively and collaboratively introduce in the long session in 2021. And essentially all that it does is it adds in patient protections for the use of telecommunications or teledentistry that currently are not explicitly stated in the statute. So it really kind of helps protect the consumer. But it also really defines what we're saying when we say teledentistry, which is important because everyone has a little bit different view, but there are market definitions that we need to consider. And I'm really excited, about the momentum, from all the invested stakeholders to make sure that this is, moving forward. So what does that mean? We want to make sure that we have continuity of payment, both through Medicaid and the private payer sector. We want to make sure that they reimburse for synchronous and asynchronous both. And then, as I mentioned, we need to look at a legislative opportunity and process. So the Dental Practice Act is Article 2 of Chapter 90, and then the Dental Hygiene Act is Article 16 of Chapter 90, which you probably already know, the folks that are on this session. But what we're looking to do is just really make sure that we have modifications of the language to allow for telecommunications to be deemed the practice of dentistry. There is a precedent that has been set by the medical board, and so the Medical Practice Act does include that information. You can see that here. That's under Chapter 90, Article 1 is the Medical Practice Act, and subsection F here that it's pointing to, it says the performance of any act with or within or without the state describing the subdivision by use of any electronic or other means, including internet or telephone. Now, what we're proposing looks a little different than that. We're not leaving it as broad as that per se, but I think what we came up with as a collective group that really made all the invested stakeholders excited is definitely going to service, at the end of the day, our end goal, which is making sure that the consumer communities have the resources that they need and the providers can connect with them as needed. So it is a collective effort, and so this is just a little screenshot of some of the language as a teaser, but this is the legislative language that we're working on. And then I had mentioned earlier the Teledentistry Grant Initiative. So we awarded, sorry, this was not updated. It says 17, we had 19 public dental health centers where we assisted them by providing them an annual subscription to a teledentistry platform of their choice. So we did not dictate which platform they used. And I want to make sure that the credit is given where it's due, and that was really an opportunity that was allotted to us with financial assistance from Blue Cross Blue Shield of North Carolina Foundation. So you'll see here, some of these are duplicated stars because the health centers were located in similar regions. Whew, okay, so a lot of talking, and I want to hear from you all for sure. A lot of you probably already have my contact information, but if you don't, my work email is at the top, and then my direct cell number is below that. As I say in many presentations, I've given my cell number out at this point, probably 10, 15,000 people, and I've never been prank called or prank texted. So please don't prank call or prank text me. But do text me if you have questions or want to chat or get involved with the collaborative or just want to talk about the status of oral health in North Carolina. You can text me, call me, email me. You can also join our email listserv at oralhealthnc.org/join. We're on all the social media platforms such as Twitter, Facebook, LinkedIn. And then to make it really easy for folks to receive our e-news, so we send out a bi-monthly newsletter and then some special edition content as well. But you can sign up to receive that by texting TEETH to 917-905-8801. And now that I feel like I'm a salesperson, I'm going to move on and also say that there are many resources in teledentistry to assist you if you want to learn more. And these are linked here. So the ADA, obviously we have many resources. This was a joint venture with the North Carolina Dental Society. So we developed this graphic in partnership with them. And then there is an actual association now for teledentistry because there's been so much momentum with it. It's called the American Teledentistry Association. And then, of course, NOAA, which is not the news weather site, but it's the National Network of Oral Health Access. They have many resources as well on teledentistry. And then lastly, I'll do one last shameless plug. If you want to learn more about teledentistry and really see how it works live in action, join us at Oral Health Day Part 2, which will be on October 23rd from 1 to 3 on Zoom. We have dental directors across the state that we have recorded live teledentistry demonstrations in clinical practice from their health centers that we're going to be showcasing to give you a really good sampling of how people are using teledentistry currently in the state. And then I'm really excited as well because we have a national, we have a panel of national experts in teledentistry, including what's deemed to be the father of teledentistry, Dr. Paul Glassman, out in California. And then we have Dr. Scott Howell in Arizona. And then we have the CEO and founder of Mouthwatch, which is one of the teledental platforms called Teledent, Brant Herman. So if you guys want to register, you can go to oralhealthnc.org/OH Day 2020. So I'll put that in the chat as well if you guys want to register. We'll have a very diverse group of participants. We have several legislators that are going to attend the event, a lot of oral health providers, a lot of primary care providers, and general community as well. All right, so I'm going to open it up to questions now. So put in the chat if you have any questions for me that I can answer before we end the session. So I put in the chat just how you can engage with us at Oral Health Day if you want to attend the event. It is free, so you can go over to our landing page at that web address in the chat to actually register. Oh, Robin, I wanted to get to your question. I'm sorry, I just now saw that. So Robin had asked a question where she said, however, does this increase the workload outside of their private practice for the dentist? So it's depending on how you look at it. So, for example, there are opportunities to review those store and forwarded diagnostic information to do the asynchronous exam, maybe during a time where there's a no-show. So maybe you have a patient that does not show up. You can actually still be productive and doing that exam via teledentistry. I see that a lot from folks that are using it currently. They say, instead of trying to get someone in, we have a whole queue of folks that are just waiting for their exam. So it works out well in terms of logistics. And then Jessica asked, will that presentation be recorded? I will talk to our content marketing specialist. I'm not sure if it will be recorded. I do know it will be live streamed, I believe on YouTube and Facebook, but I will connect with him and see what his plans are. We did record the part 1 of Oral Health Day, so I would assume we will be recording part 2 as well, and we'll have that on our website for folks that may not be able to attend from 1 to 3 on the 23rd. Well, I really appreciate the engagement. I hope this was helpful to folks. I hope it gave you a little sampling of teledentistry, and you'll follow up with us to learn more. But I'm really excited. As you can tell, I'm very passionate about teledentistry. And again, that's really based on my own clinical experience using it and really understanding the impact, the positive impact that it made on my community I was serving, but also where we're at as a state. All of the stakeholders are really excited to move forward with this. So I think that, now is a great time, and COVID-19 has been horrific for so many people. But there is silver lining, I think, in everything. And part of the silver lining for COVID-19, I think, is really pushing forward telehealth broadly, and teledentistry, as being part of that. All right. Well, I'm glad that you guys enjoyed it. Definitely, please reach out to me and let me know if you have any questions. Jessica, I know that there was something you did want to reach out and connect about after. So just send me an email and we can set something up. All right. Well, I hope everybody takes care. Enjoy the rest of your Thursday. Bye-bye.